I want to talk today about acute chest pain presentations, and I will discuss troponin ranges in various myocardial injuries as well as troponin algorithms in acute chest pain presentations. And I will also give some tips regarding non-MI causes of acute chest pain and overlooked ideas. The first two parts of this topic are mostly an extract of my non-STEMI talk, which I strongly suggest you review. Now, important ideas regarding troponin. How can we use troponin to help us decide that progression and what's the real diagnosis? EKG can be very helpful depending on the presence of EKG abnormality and how pronounced they are. They make you lean toward this or at least that one, the EKG, but troponin can help as well. And I will show you my own classification of that. This is my own classification of troponin values for various myocardial injuries. And keep in mind, there are two types of high sensitivity troponin. There is the high sensitivity troponin T, which we have at our institution here, and there is the high sensitivity troponin I, which is used at the VA and at many other outside institutions. And always when you look at high sensitivity troponin, try to figure, is this troponin T or I? Because troponin I has a 3 to 10 times higher value than troponin T. And the higher the troponin and the bigger the injury, the bigger the discrepancy. It can become 10 times higher, the troponin I compared to troponin T at higher troponin values. And here are the cutoffs I use. For troponin T, the MI cutoff is that 14 to 22. 14 in women, 22 in men. Between 14, 22 and 100, this is a zone where it's frequently a non-MI myocardial injury. Between 100 and 300 plus, it's a zone where it's frequently type 2 MI with no CAD. Between 300 plus and 1,000, it's frequently type 2 MI with CAD or type 1 MI non-STEMI. Above 1,000, it's overwhelmingly type 1 MI, frequently even type 1 MI STEMI or STEMI equivalent, the so-called acute occlusion MI, OMI. Now, evidently, there's a lot of overlap between those zones, particularly the higher level diagnosis, type 1 MI, type 2 MI with CD, may very well be seen at the low troponin value that are just above the MI cutoff. So you may very well have a type 1 MI here in that 14 to 100. In that zone, 14 to 100 of troponin, if you take all comers, type 1 MI is likely less than 50%, but 50% is a big number. So you may be type 1 MI depending on the context here, but it's frequently a non-MI injury. The key idea is that those lower level diagnoses, non-MI injury and type 2 MI with no CAD, usually don't cause the higher troponin levels, but the higher diagnosis can cause the lower troponin levels. And here you can add, for that injury zone, you can add other numbers. Instead of 100, 300, you can put 52, 100, which are used in some MI troponin algorithm. Those will be even more specific for an injury and less likely to be an MI, that 52, 100 cutoff instead of 100, 300. And those numbers, I obtained them from reviewing a lot of registries. These are some of the ones that I used to obtain the higher values. But here are some case illustration. We recently had a 65-year-old woman with chest pain and a troponin T of 35 that went up to 50. So she was in this zone here that could fit with non-MI injury. So 14 to 52 or 100 is a gray zone. More than 50% of cases are non-MI injury, but she has no explanation here. This is non-STEMI, and she has a delta of over 20%. So this is a non-STEMI. Unfortunately, she was discharged home and she returned 2 days later with inferior STEMI. So use the context and the EKG, not just that zone. But this is very helpful classification in context. This is another patient, 70-year-old man. He has history of heart failure with the F 20%. He presents with severe heart failure, pulmonary edema, lowish blood pressure, and acute kidney injury. His troponin T is 400s. EKG shows LVH and static secondary ST depression, no Q wave. This patient, his troponin is here, but I believe he most likely has a non-MI myocardial injury with or without underlying CAD. I don't believe he has type 1 MI looking at the context. And there is a good chance that even though it is 400s, the troponin, he probably doesn't have underlying CAD because he has no Q waves. Lack of Q in severe cardiomyopathy suggests non-ischemic, although some proportion, up to 30%, could be ischemic. But anyway, this is not type 1 MI looking at the presentation. This is another patient, 72-year-old man, no prior cardiac history. He's had off and on chest pain that woke him up last night, then ongoing chest pain since this morning for the last 4 hours. His high sensitivity troponin is 44, mildly increased. This is his first EKG, unremarkable. But then the second EKG, 30 minutes later, again, this patient has ongoing chest pain, so you need to keep repeating EKG every 10 to 30 minutes. So 30 minutes later, that EKG shows an abnormality that out of this context could be non-specific. He has biphasic T in V3 and multi-inversion in V4 through V6. If you're reading a stack of EKG, you will call this non-specific T abnormality. But in context, when you have evolving T waves that are biphasic or profound, this is concerning for ischemia. So that T wave here is not concerning for ischemia, but evolving biphasic T wave is concerning for ischemia. It would be particularly concerning if it had a Wellens shape. Wellens shape, the descent of that T wave will be very sharp, almost 90 degrees. So this is not a Wellens T wave. Nonetheless, it is biphasic, evolving in context, and that troponin is not easily explained. He has a primary chest pain presentation. So it is concerning. An EKG 10 minutes later shows even this, an accelerated idioventricular rhythm competing with a sinus rhythm. So now we're building even more ischemic findings. So we cath this patient urgently, and indeed, he had an occluded diagonal. You see his stump here. Occluded diagonal, and he also had severe LED disease. So we did stent both using a TAP two-stent strategy. I want to give now another third major slide. So far, I've given 2 big slides that you need to print and carry with you when you're doing inpatient cardiology. This one, as well as this troponin classification. And this is the third major slide that you need to carry with you. This slide is focused on how to manage patients in the ED, particularly at the low troponin level, below MI cutoff, or in that low gray zone. Below MI cutoff, below this 1422 for troponin T, you have very low values that are either undetectable, less than 6, or detectable but with very low delta, less than 4 in absolute, or in this zone we use, if you use a relative value, we use 50%, but we tend to use absolute delta for this zone. So if you have undetectable troponin in that negative troponin, if you have undetectable, it's not just negative, it's undetectable or detectable, but very low delta at 2 hours, this patient can be discharged safely home with a very low risk of type 1 MI or death at 30 days. The risk of type 1 MI at 30 days is less than 0.5%, and the risk of cardiac death at 30 days is close to 0%. So, and that's the beauty of high sensitivity troponin, and the advantage is that it identifies within that negative zone, a very low risk zone where you can discharge patients home. It's actually as safe, if not safer, to discharge those patients home with those troponin values than after a negative stress test. It has at least as strong of a negative predictive value for MI at 30 days as a negative stress test. Now, if your troponin comes into that gray zone, 14 to 52 or 14 to 100, and probably better to use in the US the 14 to 100. 14 to 52 works in Europe, European registries. 14 to 100 is what works better in American registries. So if your high sensitivity troponin is in that gray zone, or if your troponin is below MI cutoff, but you have a big delta over 50% or over 4, then those patients are in the intermediate zone. And those are placed in observation, and we repeat troponin in another 3 hours. If troponin remains in that gray zone, even if you have a significant delta, but you remain in that gray zone, then here you individualize. You may decide not to perform any testing, particularly if that patient already had CTA in the last 2 years or a stress test in the last year. Or you may decide to perform non-invasive testing, or you may decide to perform coronary angiogram. And if you decide coronary angiogram, it depends on the fact that this patient has delta and he has a context of type 1 MI. So for example, like those cases I showed, this one is troponin between 14 to 100, but it has a context of type 1 MI. So you may perform coronary angio here, depending on the context, and you need to have a positive delta over 20% to decide so. Now, if the troponin is over 52 or 100, this is the higher risk population. That doesn't mean you need cath, but you generally need admission. You need to decide, is it type 1 MI or type 2 MI or non-MI myocardial injury? Is there a type 2 mechanism, cardiac or non-cardiac major illness causing the troponin rise? And you may decide to do coronary angiography if delta is over 20% plus no concomitant acute illness to suggest type 2 MI or non-MI injury. Keep in mind that across population studies, troponin over 52 had only a 50 to 60% positive predictive value for type 1 MI. So even when you're in this zone, half the time you're not type 1 MI. You're either non-MI injury or you're type 2 MI. Particularly in the US, less than 50% of patients in this category end up having type 1 MI, more than 50% in European registries. And this is improved by using 100 rather than 52 cutoff. Another important idea with this algorithm, and I think if you print, you need to print that slide, is what do we call significant delta. For the very low troponin values below MI cutoff, we use absolute delta 4 for troponin T, or a 50% in relative term based on a JAMA paper published in 2011. But above the injury cutoff, it's 20% that's considered significant delta. Sometimes with that gray zone, 20% is a little less specific. I would be happier with something in the realms of 20 to 50%. But nonetheless, if you want to pick a number, it's 20%. Now, if delta is in those zones is less than 20%, this is what we call a chronic non-MI myocardial injury. This one here, it's a chronic non-MI myocardial injury. And in those patients, ischemic workup is even less justified than even that gray zone, and definitely less than that. You overwhelmingly and most often you do not need to do ischemic workup, but again, take into account the EKG and the context. That delta applies to all troponin assay, whether high sensitivity troponin T, high sensitivity troponin I, or the conventional troponin for hospital that still use the conventional troponin. So here are some ideas. Within the low high sensitivity troponin, very low values, whether undetectable or detectable with low delta, imply low risk and safe discharge with negative predictive value over 99.5% for type 1 MI and close to 0% risk of cardiac death at 30 days. Even the rule-in black zone, this zone, only has a 50% positive predictive value for type 1 MI, maybe even less so in the US, and this is improved by using a higher cutoff in the US of 100. Importantly, in all comers with chest pain or suspected ACS, hs-troponin T cutoff of over 52 nanogram per liter has a limited positive predictive value for type 1 MI of only about 50 to 60%, and even less so in US studies such as those three here. In fact, in this one, the positive predictive value for type 1 MI was even less than 30% for the cutoff of 52. That is why in the US, a cutoff of over 100 may be used. Now, regarding that gray zone here, the positive predictive value of hs-troponin T in the 22 to 52 range is less than 50%, even less than 30% in those studies here. Therefore, depending on the context, this range, the gray zone range, may qualify for non-invasive coronary testing or no testing at all. But again, take into account the context. If, depending on the population studied, up to 30 or even 50% of those gray zone patients have a true type 1 MI, that's not a small number. So if he's presenting with no other explanation for the chest pain and no other context, this patient would qualify for coronary angiography. Importantly, and that's an important idea for me, clinical scores like heart, TIMI, and others do not improve the safety of this algorithm and unnecessarily reduce the proportion of patients ruled out. So confusing and complicating this algorithm by adding a heart score or other scores will lead to more admissions and more testing. They will lead to less patients ruled out because they have heart score because of their age or their chest pain description. And you'll end up with less discharges. And actually, there are two European studies, those two here, that have shown that adding heart score does not improve the safety of this algorithm. It's already safe with over 99% negative predictive value at 30 days without using the heart algorithm. There is this American study here that tried to spin the data and show that heart score improves negative predictive value by 1%. But in fact, the negative predictive value, even in that paper for death type 1 MI at 30 days, was not improved and was still less than 1% without the heart score. And using the heart score came at the cost of a massive decline of the rule out value. And these are some of the studies I used to derive that algorithm. And you can review more information regarding that rule out ED management in the 2022 ACC expert consensus pathway and the ESC guidelines. They have their algorithm. I made my own based on the data, and it's somewhat similar and compliant with the ESC and ACC guideline, except it's a little more detailed, and I take into account various cutoffs from various studies. And they use here, you see that 52 cutoff. Now, other important ideas regarding troponin. When does troponin rise after MI onset? When does troponin peak after MI onset? And how to diagnose a recurrent MI in a patient with elevated troponin? So troponin rises within 1 to 3 hours of MI onset. It may take up to 3 hours, but frequently it rises at 1 hour. It peaks at 24 hours in non-reperfused MI and stays elevated for 10 to 14 days. It peaks a little sooner in patients who had acute recanalization, especially in STEMI. So it would peak around 14 to 16 hours in recanalized acute STEMI. Otherwise, it peaks around 24 plus hours. So it starts to rise 1 to 3 hours, peaks at around 24 plus hours, and stays elevated 10 to 14 days. This is extremely important. This will give you two ideas here. In MI, the troponin will continue to rise until 24 plus hours after the initial event, even if ischemia of that initial event is alleviated. Troponin peak sees the past. The troponin that continues to rise does not mean you have ongoing ischemia. If the patient had chest pain at 8 this morning and at midnight his troponin continues to rise, it was 40 and now it's 500, that doesn't mean he's still having ongoing ischemia. If he's doing well and he's chest pain free, he had 2 hours of chest pain in the morning and he's no longer having chest pain, that doesn't mean he's having ongoing ischemia. You don't need to be alarmed by the fact that it's still rising in terms of he's having ongoing ischemia. You need to be alarmed if you had overlooked the initial diagnosis. If you dismissed his initial presentation, then yes, you need to be alarmed and adjust your treatment. If you weren't planning on cathing him, you need to cath him, not urgently because he's not having ongoing ischemia now, but you need to potentially change your strategy if you miss the initial diagnosis. But you don't think he's having ongoing ischemia. Very important. Troponin peak sees the past. The peak tells you how big the initial event was, not that it is still ongoing. That's one of the most common mistakes I see among fellows, and especially internists and residents. Now, another major idea that arises from that troponin kinetic is understanding that plateau. So after you peak, you get a slight and slow decline and a plateau over 7 to 14 days. And this is a zone where you don't get delta. That's about the only place where you don't get delta in MI within a few hours. So if you check troponin within a few hours in a patient coming 2-3 days after his MI, you may not have delta over 20%. You're on that plateau phase. On the plateau, you will get bumps. Troponin may go up a little bit, down a little bit, probably less than 20%. So you get that bumpy plateau. And that plateau is important, one, because you realize, you don't have delta in this. That doesn't mean you don't have an MI, you mean you're late. 2, it helps you time an MI, especially STEMI. STEMI, sometimes you need to figure out, is it less than 24 hours, more than 24 hours? If your troponin is at a plateau, it's not having much delta anymore, or if your troponin is declining, if you have a very high troponin that is declining or plateaued, that also tells you your presentation is over 24 hours. It's a late STEMI presentation in the case of STEMI where you're trying to time it. So that kinetics help you time MI, and that's another reason why it's important to understand. Now, how do you diagnose recurrent MI in somebody with a high troponin? It's a re-rise of a declining troponin of over 20%. Now, if the troponin is still on the rise, how do you diagnose recurrent MI? You do need that 20% further rise, but it's not enough because, again, the troponin will keep rising anyway because it's seeing the first event. So if he has another event here in the first 24 hours, how do you know it's a recurrent MI? Well, you need to rely on the clinical history in that case and the EKG. And the fact that it does need to rise more than 20%, but again, in this area here, it's not enough because it's going to rise anyway.